This is A Pet for My Heart by Dr. Tephilah from Medicine 5.
Good morning, everyone. I'll be presenting on behalf of Medicine 5. The title for my presentation is A Pet for My Heart. So presenting Mr. L, he's a 73-year-old gentleman from Manipur who had presented with history of breathlessness, anasarca, decreased urine output for 2 months, and history of fever for 2 days. So the breathlessness was insidious in onset and gradually worsened from NYHA 1 to 3 over the last 2 months. And there was also history of orthopnea and PND. And he also developed generalized body swelling. It started with his lower limb, and he also developed scrotal swelling and abdominal distension. And the patient also had decreased urine output in terms of frequency as well as volume over the last 2 months. And for the last 2 days prior to presentation, he had low-grade intermittent fever, and but he did not have any cough or cold, burning, micturition, or loose stools. And for the same, he had taken pip-taz from outside. So coming to the past history, he was diagnosed with rheumatic heart disease, and he underwent a dual valve replacement. So this is a mitral valve replacement. It's called the ball and cage valve replacement, and he also had an aortic valve replacement. And this was done in CMC in 1996, and oral anticoagulation since then. He's a known case of diabetes, hypertension, and hypothyroidism. At presentation, he was tachycardic with a heart rate of 122. It was irregularly irregular, and he had pallor and pedal edema. There was also scrotal swelling and elevated JVP. The cardiovascular system examination had a prosthetic click heard at the tricuspid area with a PSM in the tricuspid area and an ejection systolic murmur heard in the aortic area. And there were also bilateral basal crepitations along with a hepatomegaly. So this liver was 4 centimeters below the costal margin. So summarizing, the patient presented with a clinical syndrome of dyspnea with orthopnea and PND, anasarca and decreased urine output, along with a history of fever with a background history of rheumatic heart disease with a dual valve replacement. So what did we consider? One was a heart failure. We thought it could be a new onset prosthetic valve dysfunction. We thought it could be an infective endocarditis. We also considered other causes of anasarca with decreased urine output and breathlessness, like a renal cause or hepatic cause. And for the acute fever, a history of 2 days, we also thought could be dengue, scrub typhus, or pneumonia. So the investigations did not show the anemia. The HB was 8.9. Counts, and the NT-proBNP was elevated. This was a chest X-ray. So as you can see, there's a cardiomegaly, and this is the ball and cage valve, and this is the aortic valve replacement. So even in the echo, you can see that there is a ball and cage valve, and the patient had tricuspid regurgitation, MR also, and the patient had pulmonary arterial hypertension. But there was also new onset elevated transaortic gradient across the aortic valve. We had initially planned to do a transesophageal echo, but because the patient had a ball, like a prosthetic valve, and especially since it was a ball and cage valve, it is known to have a lot of artifacts. So it wouldn't pick up, it's not sensitive for picking up infective endocarditis. So we went ahead and did blood cultures. Out of the 5 blood cultures that we had sent, 3 of them had grown Streptococcus viridans species, and among that it was a Streptococcus sanguis. And this was sensitive to, it was a sensitive, and even the penicillin MIC was low, it was 0.094. So the diagnosis we have was a prosthetic valve infective endocarditis with a Streptococcus viridans. So in this case, the patient had a prosthetic valve. So as I mentioned earlier, the problem with having a prosthetic valve is that for reverberation artifacts. So you can see that in all 3, so this is what a patient had, the third one, that is a ball and cage valve, that there are a lot of reverberation artifacts. So it's very difficult to use a transesophageal echo or a transthoracic echo to identify vegetations. So to tide over this problem is where the new Duke's criteria comes in. So here they use PET-CT for the imaging of the prosthetic valves. So I like to highlight the indications of PET-CT in infective endocarditis. So the main 2 indications for using a PET-CT in infective endocarditis is 1, to detect any intracardial infections, and 2nd, to detect any clinically silent disseminated infectious disease. So the diagnostic performance of this PET-CT in infective endocarditis depends on whether it's a native valve, prosthetic valve, or if it's an implanted cardiac device. So this is a meta-analysis which shows the use of using PET-CT in diagnosis of infective endocarditis. So as you can see, in a native valve infective endocarditis, the pool sensitivity is quite low. It's only 31%, but it has a high specificity, around 98%. So if the PET-CT is normal, it does not rule out an infective endocarditis. But in a prosthetic valve endocarditis, the pool sensitivity is high. It's and the specificity is 84%. So in a prosthetic valve, the using PET-CT has actually high sensitivity and specificity. So this is a table again which highlights the same thing. In a native valve, the sensitivity is low, whereas in a prosthetic valve and a cardiac device, the sensitivity and specificity is higher. So now coming to the timing of PET-CT in an infective endocarditis. So ideally, we have to use a esophageal or a transthoracic echo whenever it is possible, because one thing, it is safe, it is cost effective, and it is widely available. And also, TE has a good diagnostic accuracy in a native valve endocarditis. But suppose we do need to use a PET-CT, we have to do it as soon as possible. One, because we have to do it before the start of treatment, but it does not mean we have to delay treatment just for the PET-CT. If we do the PET-CT after antibiotics, it can be falsely negative. And also, if the CRP falls below 40, it will again be falsely negative. And recommendations also say that if the patient has a cardiac surgery, if the PET-CT is done within 3 months, then it will be falsely positive. So it has to be done after 3 months. So just a point about how to, we all know that patient has to be fasting and the cardiac myocardium is metabolically active. So there are 3 things that they do to reduce the metabolic activity of the heart. One thing is they give something called as a high fat, low carbohydrate diet. This is because the myocardium prefers free fatty acids over glucose for its metabolism. So when we use this, it reduces the cardiac glucose consumption. And that's the same principle of giving heparin, because it causes free fatty acid release. And corticosteroids should be avoided. So how do we interpret the PET-CT? If it's a homogeneous uptake, it points to reactive inflammation and not infection. Whereas if it's heterogeneous, and if there's also spread to the surrounding tissues, and if there are metabolically active lymph nodes, then it points to an infection. So in our patient, since the patient had a prosthetic valve, and especially a ball and cage valve, we could not do a transesophageal echo. We did a PET-CT. So in our patient, actually, it did not show any heterogeneous uptake. But again, it does not rule out an infective endocarditis because the patient fit into the other criteria. So now coming back to how we managed our patient, our patient had Streptococcus viridans infective endocarditis. So this belongs to the alpha hemolytic group of streptococci, and it's a common cause of native valve, commonly seen in prosthetic valve. So this is a graph which shows that if the patient has streptococcal blood infection, the risk of actually having infective endocarditis. So you can see that the patient who has prosthetic valve has a high risk of having infective endocarditis if the blood grew streptococcal streptococcus. And also among the streptococcal species, if the patient had sanguis, there's a higher chance that the patient had infective endocarditis. And our patient had streptococcus sanguis. So just a brief management. So our patient had a penicillin MIC of less than 0.12. So both the AHA and the European Society have recommended a penicillin or ampicillin or ceftriaxone with or without gentamicin. So how did we manage our patient? We had started the patient on ceftriaxone 2 grams once a day. And the patient developed AKI in the ward, so we could not start gentamicin, but the plan was to start gentamicin once the creat reaches baseline. He was also planned to follow up under cardiothoracic surgery OPD to decide on valve replacement. So the take-home points are the indications of using PET in an infective endocarditis and the management of Streptococcus viridans that is sensitive to penicillin.
Thanks, Tephilah, for a nice presentation. Are there any questions, audience? I'm going to say. Thanks for highlighting.
our patient did not show, but PET seem, according to the current evidence, PET seems to be the investigation of choice for prosthetic valve abnormalities. So I think that, and like Tephilah said, this negative does not mean the patient is in an infection and satisfied. It is the investigation which is in the early stage. So once it's more refined and people are more comfortable with it, we'll be able to have better outcomes.
Thanks for highlighting using a newer technique for evaluation of a very common problem that we see routinely. Thanks.